So it's preparing the live streaming preview. So it's setting up live streaming. So I'm live now. Okay, so welcome everyone to another BREDS webinar. This is, we're very excited to present this. It's diabetes and eating disorders, which we know a lot of people are very interested in as a topic. And we're delighted to welcome three distinguished speakers on the topic. So we've got Dr. Marietta Stadler, who's at King's College Hospital, specializing in eating disorders and type 1 diabetes. We've got an expert by experience, Lawrence Smith, and we've got Emma Constantara, who's a PhD candidate at King's College London, who specializes in this area. So without further ado, I'll hand it over to Dr. Marietta Stadler. By the way, whilst the presentations are going on, feel free to make comments on BREDS, and we'll use on the workplace, and we'll use those to as a way of asking questions to the panelists for the end of the talk. Okay, so if I hand over to Marietta.
Thank you, John. Good evening, and thank you for the invitation and introductions. My name is Marietta Stadler. I'm an NHR-funded clinician scientist, work at King's College London and King's College Hospital, and I'm a physician diabetologist by background. And in more recent years, I've taken a deeper interest in complex type 1 diabetes and mental health problems. So I will be co-presenting with Emanuela Constantara, who's working on an exciting PhD project, which you're going to hear about, and with Lawrence today. These are our email addresses, so if you've got any questions to send to us after the presentation, please do send me an email. So I know we've all been to med school at some point. I just thought it may make sense to recap what diabetes is, in particular type 1 diabetes, because type 1 and type 2 diabetes are quite different conditions. So type 1 diabetes is caused by an autoimmune destruction of the beta cells, leading to an absolute insulin deficiency. Means that the person living with diabetes needs insulin injections for life, i.e. lifelong, and to survive. It's a 24/7 self-care chore. With type 2 diabetes, the majority of people with diabetes have got type 2 diabetes. The background pathogenesis is insulin resistance combined with beta cell failure, and it's quite a heterogeneous phenotype. And typically there is a relative insulin deficiency and a progressive nature of the condition. Both types of diabetes can have comorbid eating disorder or disordered eating, but today I'm going to focus on type 1 diabetes because this is what our research program at King's is about at the moment. But it doesn't mean that I'm sort of ignorant of the massive problem that also exists in the group of people living with type 2 diabetes. So as a metaphor, to understand what living with type 1 diabetes may be like, I'm quoting a metaphor that people living with diabetes have given to me. They say it's like walking the tightrope, and some say it's like being on a tightrope with a unicycle or even a burning unicycle. So while we all have things on our mind like family, work, friends, hobbies, things that matter to us, if you live with diabetes, you also have to consider how much food you eat, how much insulin requirements you will have if you're ill, if you're pregnant, if you exercise, and you have to find that really delicate balance between too little and too much insulin, just the right amount of insulin, which is incredibly tricky. So if you fall off that tightrope, you may have an unconscious hypoglycemia episode, or if you're behind the steering wheel, you may crash your car. Or you are worried that you may have complications later on in life. Or the other extreme is the ketoacidosis, which is a metabolic emergency caused by absolute lack of insulin. So it's not surprising this is an exhausting chore, and it's not like a job, it's actually worse than a job in a way that there is no break, there is no annual leave, and there are no weekends. So just to contextualize why it isn't surprising that disordered eating as one of the mental health problems in type 1 diabetes are actually more common than we think they are. So we know that traditional eating disorders, as in anorexia nervosa and bulimia nervosa, are about twice as common in people who are living with type 1 than in people who do not have type 1 diabetes. But if we expand the definition of disordered eating to those who deliberately restrict their insulin to control weight, so putting their health at risk to lose weight or to not gain weight, that would mean that about a third of women and about 10% of men, or even more, are affected by this type of eating disorder. And not taking one's insulin, or taking less than one needs or more than one needs, can lead to acute complications of diabetes or accelerate the so-called late complications of diabetes. And this all is a really dangerous combination. These context between type 2 diabetes, just to mention that here for completeness, it's, as I said, not part of this talk, but we know that eating disorders are also quite common in type 2 diabetes. Binge eating disorder and bulimia even triple the risk for getting diabetes later on in life. However, there may be a joint root, as in insulin resistance is found in both these eating disorders and also in type 2 diabetes. But we do not know the proportion of people living with type 2 who have an eating disorder, because there's no research on it. There's some anecdotal smaller studies identifying binge eating disorder and night eating syndrome as the most common disordered eating behaviors. And in specific subgroups, you find quite a high prevalence of binge eating disorder, but we do not know how that impacts on outcomes. There are no longitudinal studies. There are no clear data on that. So this is uncharted territory. For type 1 diabetes, we know there is no intervention out there that works to improve glycemic control alongside improving the disordered eating behavior. So we've put together a really large collaborative across King's Health Partners, across eating disorder services, diabetes psychiatry, psychology services. So this slide is getting more and more crowded every time I give presentations. So we really have a good momentum here of national collaborators who are all interested in finding something to help this group of people. And NIHR has bought into the concept and funded a 5 years research program. So what are we doing at King's Health Partners at the moment? We've got 2 big projects running. The STEADY project is led by myself. We are developing in a team-based and multidisciplinary approach a intervention that's quite complex, but merges cognitive behavioral therapy elements with diabetes education and physical and mental health input to help people who are moderately ill with type 1 and eating disorders. And the NHS England funded TIDE pilot project has developed a clinical service for people with type 1 diabetes and eating disorders in London who are severely ill, and this is led by Professor Khalida Ismail. So first of all, the problem we're running into right from the start with all these interventions that we're planning to deliver is we are unsure how to define disordered eating and eating disorders in the context of diabetes. There is no clear consensus, but we know there's a wide spectrum. And Emma was going to talk you through more of this, because this is what her 3 years PhD project defined would be about. But at King's Health Partner, we currently have a working definition around core criteria that one has to have type 1 diabetes, a pervasive fear of insulin as causing weight gain, and omitting insulin to control weight. And the severity indicators indicating a high indicates severity. The STEADY project comes with a We've conducted a mixed method study to combine glucose measurements that were continuously done for a week with self-made entries into a diabetes app that monitors diabetes self-care behavior to understand how the two link together. And obviously also Emma's project, and we are in the process of refining the theoretical models of what maintains disordered eating in type 1 diabetes, and also developing a recovery model. So coming back to the link I'm really interested in is that the condition type 1 diabetes comes with enormous swings of ups and downs of blood glucose, which obviously will impact on mood, on well-being, but also can trigger disordered eating behavior and the other way around. So we were really interested in how that links together, because if we were to develop a therapy, we really have to take the very nature of type 1 diabetes into account for it to work. So people volunteered to wear a sensor for a week that measured their glucose in the interstitial tissue. And they also recorded whatever they felt was relevant to their diabetes into a diary app called MySugar. So to give you an example, this participant took a picture of her meal here. She put down her blood glucose levels, how many grams of carbs she had, and what she had to drink with it. And she also later on documented she was a bit hypo, was a bit tired, had a bit of a headache, but was overall happy. So we had data of a week that people gave us and then tried to bring them together. Apologies for the busy slide. The key message is that people with type 1 diabetes who have an disordered eating have constantly higher blood glucose levels. At the percentage above range is a lot higher in this group, and they have got much more pronounced up and down swings of their glucose. So indeed their glucose is more volatile. We learned a lot in that study, as in what the picture looks like of people's glucose levels, and it's quite different, as you can see on this slide. So I've selected 3 of the 24 people we studied. The top one shows you an overlay of 7 days worth of glucose readings. So one line is 1 day, and the green zone is between 4 and 10 blood glucose, and below that is hypoglycemia, and above that is time above range. So this is a person with eating disorder who's very fearful of hypoglycemia. So she runs her glucose high overnight, then wakes up, feels bad about it because she's worried about complications in the future, and gives a lot of insulin and drops into hypoglycemia, which then in turn triggers binge eating, because hypoglycemia is a real threat to the body and gives a signal to the brain, you have to eat now, otherwise you're going to run out of fuel. So she is on that, starts her day on a real roller coaster. This participant reviewed these traces together with me after she took part and said, oh, that's interesting. I must have gone back to emptying the fridge in the night. So she reported that she had nocturnal binge eating in the past. She's now aware of daytime binge eating, but this was actually a diagnostic tool to help us discover this. And the panel at bottom right is a woman who very kindly agreed to help with the study, because she wants to really help us develop an intervention. And to wear a sensor, you have to calibrate the sensor twice a day, at least during that time. So the only reason she gave insulin was to be able to calibrate her sensor to take part in the study, and otherwise she was purging through just running her glucose levels high. So she would shed glucose via the urine and lose calories, and she would also get herself into a catabolic metabolic state, which caused her to lose weight. So this is how different this illness can look like, and hence it's quite difficult to define. So from these data and from the interview data, and all compiled and sitting together in workshops, I can give you one example of the maintenance cycles we have developed and also had reviewed by our people with lived experience, whether this is something they feel is relevant to them. So for example, how binge eating and type 1 diabetes can play together. For example, you have hypoglycemia. Hypoglycemia said is a strong trigger to eat and can trigger a binge eating episode. After the binge, there's feeling of disgust and shame and low mood. And it can now go either way. Either the fear of weight gain is the dominant trigger, which then can lead to just not giving insulin for the calories that have just been ingested, with then later on feeling really unwell because of the blood sugars running high and thinking, well, I don't want to take extra insulin, so what do? I restrict food. And the restriction then triggers the next binge. The other cycle goes that way, as in I've been binging, my blood sugar levels are high, I'm a bad diabetic, I'm fearful of complications, and now I give a lot of insulin to bring the blood sugar down. And then that can trigger the next hyper because of just giving too much insulin in that emotion of wanting to get the blood sugar down. So you can see it's very interesting how the diabetes and the thoughts and emotions can play together here. In focus groups, the key message is that we need to collaborate. Diabetes and mental health specialists across disciplines, together we can move more out of our comfort zones and can use our skills complementary to help our service users. So that was the key message. A very strong element in the study project is the PPI workstream. So we have people with lived experience as co-designers in our workshops on eye level with the health professionals with the lived experiences of looking after service users with type 1 diabetes. And together, so this workstream is led by Dr. Jacqueline Allen, who also founded the DWED self-help group. And together, you can see a picture of one of our co-design workshops here. In 6 consecutive workshops, we've now developed a study toolkit, which is an intervention toolkit that will be delivered by Jenny Brown. Jenny Brown is our diabetes nurse specialist who is also now trained as a CBT therapist. And she will, as part of a multidisciplinary team, be delivering these intervention toolkit elements in a bespoke way tailored to the person. And we're hoping to roll this out soon as a randomized control feasibility trial. COVID got into the way, but as soon as we are safe to do so without putting participants or staff at risk, we hope to put this to the test. This is why I just wanted to remind all of us that this is really a group effort. And it's Emma and me here this evening today, but there are many people supporting this and actively collaborating on this project, and also the people with lived experience who I'm very, very grateful to. On this point, I'd like to hand over to Emma. I hope I haven't taken up too much of your speaking time.
Thank you. Let me see if I can share my screen first. Oh, I cannot share it while you're sharing.
Yes, I'm sorry. I'll stop sharing.
So first of all, hi, my name is Emma. I'm a PhD student at King's College London. I'm working on eating disorders and type 1 diabetes. I will present my PhD plan today. And of course, feel free to contact us if you need any more information. So I hope you can see my screen now. I will assume this is. So my project is called Define the Project, defining the spectrum of eating disorder phenotypes in people with type 1 diabetes. So just a quick recap of what Marietta said. What we do know right now is that people with type 1 diabetes are more likely to have or develop an eating disorder. The incidence of type 1 diabetes increases annually. Eating disorders have the highest mortality rates of any psychiatric disorder. People with, we call it TIDE, type 1 and disordered eating, are more likely to develop complications. There is no official definition of TIDE and no golden standard for the TIDE treatment. So what this actually means in reality is that cases are underdetected and undertreated. So that leads to complications and high morbidity. There is a lack of preventative interventions. The patients do say that they have a very low quality of life, and that denying provision of social validation of the sick role is very important to them. We have had people saying that they feel that they are crazy because they are not sure if they do have a condition that they should be worried about, or if they are making this up. So actually, even the definition itself, the diagnosis itself would give people a lot of peace of mind. And then of course, adding to the complications, you have an increase in healthcare costs. So the aim of my work is exactly that, to define the criteria for eating disorders in type 1 diabetes. The problem with that is that there is no formalized process to arrive at a consensus in recognition of a new disorder. So first of all, starting with the basics, how do you define definition? A new condition must have sufficiently different clinical characteristics from other known conditions. It has to have appropriate limits, so not be too broad or narrow. It has to be replicable, so observed and confirmed by qualified medical practitioners from a range of subdisciplines. It has to have common feature of cause and effect, and we have to consider the context in which it emerges, as it is important for its acceptance or rejection. So my project has 3 different work packages. So the first work package is a systematic review, where we want to see basically what is out there, how do people define eating disorders in type 1 diabetes, since there is no official definition. Then there is a qualitative phase, which has 2 different aspects in it. First of all, we want to explore the experiences of people living with TIDE, and we want to identify and cluster the different types of eating disorders in type 1 diabetes. So this will let us create case vignettes that we will show and discuss with healthcare professionals, but also people with lived experience in the third work package in a Delphi workshop, where we can discuss this and develop the diagnostic criteria for TIDE. So first of all, the systematic review. Our research question is, what are the diagnostic criteria currently used in literature to define TIDE? And the objectives are to map systematically the diagnostic criteria used, to list the theoretical rationales for the chosen diagnostic criteria. So why did the researcher choose to define TIDE in this way? To identify the groups and clusters of the key characteristics of TIDE definition as it is perceived by researchers, patients, and healthcare professionals, and document any evidence of validity that might be out there for the diagnostic criteria chosen to be used. So first of all, in our qualitative phase, we want to explore, and we will do that by working on our new research, but also taking into account everything we have learned from before in the team. So we want to focus on 3 populations. This table is read better vertically. So the population that we want to talk with is people with type 1 diabetes, people with type 1 diabetes and disordered eating, and healthcare professionals. We have various data sources that is discussed. So from our previous work, we have done a barriers project where we interviewed women with and without type 1 diabetes and to learn their experience. So in addition to that, in my PhD, I have interviewed men because we wanted to see if there are any differences between the 2 genders. We know that eating disorders are very under-researched in men in general, but even more so in type 1 diabetes. And we have done the same for people without disordered eating and also people with disordered eating. In terms of the people with disordered eating and type 1 diabetes, in addition to the barriers project and the defined for men project, we will take into account the data that we will see from an NHS England pilot. So NHS England has kindly funded the first pilots in the world, as far as I know, that are specifically focused on people with type 1 disordered eating. These are in 2 sites in London and Bournemouth. The reason that we wanted to add the experience of people that are hospitalized and participating in the TIDE pilot is because until now, we have data from people with minor and moderate severeness of illness in disordered eating, but we could classify the patients in TIDE in the NHS England pilots as severely ill. So because of that, we have decided not to interview them directly, but to actually read their clinical notes and their electronic patient records and extract all the relevant data that we can find from there. Now, from healthcare professionals, our team has already done some work on focus groups from healthcare professionals, and we will use all of this to analyze them with comparative thematic analysis and derive in some findings. We will also use both qualitative and quantitative data. The reason is because type 1 and disordered eating has a lot to do with mental health, but also physical health. So we want to find about the behavioral patterns within an eating disorder cycle, any obstructive thoughts related to eating disorder, weight, body image, resilience factors related to eating disorder management, personal behavior, past traumatic experiences with self-harming, any important events. But also we want to know people's demographic characteristics, physical health information such as years since diabetes diagnosis, BMI, blood pressure. We want to know about their mental health well-being, such as results from questionnaires, validated questionnaires, reporting anxiety, depression, mental health comorbidities, their medication, hospital admissions, complications, and type of care they have received so far. And when we take all of this into account, what we want to do is create case vignettes. So we want to take these case vignettes and cluster them. So first of all, we will deduct the phenotypes of type 1 disordered eating. We will group and cluster the key characteristics, identify the common combinations, and assess the risk using a traffic light system. So again, low, moderate, and severe type of illness. And once we have these, we will co-develop the diagnostic criteria for TIDE with people with lived experience and healthcare professionals. So in order to do this, we will employ the EBCD, so experience-based co-design, and Delphi method workshops with all of these groups. The EBCD has a very specific and structured methodology it starts with setting it up, engaging staff and gathering experience, then engaging patients and gathering experience, co-design meeting where all the groups meet, small co-design teams, and celebration events. We will, of course, due to COVID, try to do more of a virtual EBCD and merge this with Delphi methods, and that is a work in progress. And that is it. Thank you.
Okay, thanks very much, Emma and Marietta. I know the next piece is going to be Lawrence. And Emma, do you want to kind of have a dialogue with Lawrence? Is that the way that we're going to do this?
Yes, of course, no problem.
Lawrence, hello.
Hello.
Hi, Lawrence, would you like to introduce yourself first?
Sure, absolutely. I'm just making sure that my phone is absolutely on silent. That would be horrifically embarrassing. So hello, I'm Lawrence. I'm an actor and a singer. I'm living in London at the moment, originally from Scotland. Emma and I have had multiple conversations in the past couple of months. So that's one good thing for me personally that's come out of lockdown. Is the chance to bore Emma senseless with all my ramblings. So I'm really dead chuffed to be here tonight. Thank you so much for having me.
Thank you, never bored. So would you like to tell us a bit about when were you diagnosed with diabetes, first of all?
Absolutely. So I was diagnosed with type 1 diabetes when I was about 3 years old. So that was in the Highlands of Scotland back in 1994 or 5. So I was originally diagnosed with a case of mild diabetes because at the time in the early 90s, that was apparently a thing. And that's just what our local clinician came up with. I have a history of diabetes in the family. So my maternal grandfather had type 1 diabetes as well. So then when I presented with the symptoms, my family were all too aware of what it entailed. So I guess I was predisposed to developing the condition. Then about 6 months later, my elder brother, he also got type 1 diabetes as well. So for me personally, it was fairly par for the course, really. As far as I was aware, everyone had diabetes unless told otherwise. In my naive childlike state, it became just very much part of my everyday life. And my parents were fantastic with the management of it, because obviously as a child, I was incapable of looking after myself thoroughly. So it became a very much a family affair to maintain the health of myself and my brother as well. So yeah, that's a general snapshot.
And growing up, did you feel any different than other people in your school?
I guess so, in that only that because it was so well managed by my family, and therefore my primary school were notified, so they kind of knew what to look out for. We had the necessary supplies lying around the classroom if Lawrence was starting to take a bit of a tumble. But I have to say, because I was in the hands of two very responsible parents, I was very lucky in that I didn't really suffer many consequences, or I was aware enough that, oh, for doing physical exercise in the playground, that I should probably have something to eat to supplement that. So from a very early age, I would equate blood sugar management and food management. They would be very closely linked. And well done, Lawrence, you looked after yourself. Well done, Lawrence, you ate. Which happened to be a neural pathway that was created from a very early age, so that when later on in life, when I started to abuse that system, it's because it was already so deeply ingrained in me that the relationship between my blood sugar levels and food and behavior. But in regards to other kids, no, not, you know, in the way that you're 7 years old. I don't know. Everyone's a bit different. Everyone's exactly the same. Really, you're blissfully naive to everything else. So I wasn't made to feel othered, and I think that was very much due to my family setup, in that my brother was diabetic, my grandfather was diabetic. It was so normal, and I've equated it in the past to because I was diagnosed at such an early age, I don't have an appreciation for not being diabetic. It's in the way that someone says, oh, talk to me about diabetes. Well, you tell me why your eyes are blue. I don't know. That's a biology that is with my reach. I just know that as far as I can remember, I have been diabetic. So for me personally, I haven't had to, there hasn't been the trauma which some other folks experience of having memories of a normal life pre-diabetes. So I'm lucky in that I've always had it, like in some way, in that I don't have memories of what it's like to live without it. So it's been very normalized for such a long time. Yeah. And
do you remember, because you said about that, Lawrence, well done, you ate your food. Do you remember if you used to eat at some point due to pleasure? Did you use food more like a treatment?
It was interesting. I think I developed a relationship with sugary foods, in that, first of all, they were withheld for a very long time. My parents would only allow us, it would be on a Friday night or a Friday after school. You've got through the week of school, and then you get treats on a Friday. So I think they tried to introduce a very stable diet because it's healthy anyway. So no, there wasn't much extravagance in the diet for a very long time. But I think, yeah, I mean, you know, birthday parties and stuff, you know, I would try as much as I could to enjoy that. But I think even as a child, there's still in the back of your mind, you are aware that, well, hang on, too much of this isn't a good thing. Too much of this is a bad thing. Like there could be serious repercussions for things that other kids are taking for granted. So actually, going back on my previous answer when I said everything was fine, actually perhaps it wasn't. I think even at an early age, there perhaps was a slight feeling of unjustness, and which I probably couldn't verbalize, or I couldn't really go into greater emotional depth with it. But yeah, I suppose there were some feelings of, well, hang on, something isn't quite right and something isn't quite fair as a result of that.
And when you started having more of disordered eating symptoms, do you remember around how old were you, or how it started?
Yes, so that was slightly later on in life. That was towards mid-adolescence, and I link it back to a variety of things. There was a few occurrences in my life. The maternal grandfather that I mentioned with type 1 diabetes, he unfortunately passed away. So that was traumatic, and things like I was getting older and having to envision a future out with the safety net of my family. I was having to think about university and going off, and I struggled very much with that, and feelings of a complete lack of self-confidence, and so a multitude of things occurred, and I felt incapable of dealing with them strategically and healthily, and I was also struggling with the diabetes, I suppose, because whereas before so much of the care and the attention and the management was in the hands of my parents, who, as I said, were incredibly responsible and knowledgeable, they knew what to do. Naturally, as I was getting older, they were thinking, well, if he's going to start learning how to drive a car, he might as well learn how to administer his injections properly and bits and bobs. So they were passing on the duty of care to me. And I don't know if it's a pathology of myself. I'm not great in positions of responsibility. So I think I kind of took it on the chin in a kind of like, well, I'm going to have to do this at some point. And I think I dropped the ball ever so slightly. I think I was given the responsibility and I didn't quite know what to do with it. So as these other events in my life were occurring, and it felt like so many things were out of control, something that I felt I could control was my diabetes, because as it's right there. The means to do so are always within hand's reach, and it became, I think, the a very dangerous thing with diabetes is it's so easy to abuse it. As in it doesn't take that many steps for something from you to go from a very healthy state to very unhealthy very quickly, which is obviously incredibly dangerous, and I warn against it. But for someone who is in a very negative state of mind, it's quite an intoxicating, or it's a very powerful thing to possess.
So when you started having disordered eating, because you mentioned about your diabetes, did you have any goals to change the way you look, or the way that your weight, or was it more about controlling the diabetes?
I think it was a dangerous marriage of the two. I think I had started at that point to rebel and to I think rather than just accept the unjustness of the diabetes, I think by that age I'd started to really get pissed off with it, and so I was trying to find a way to. This wasn't the primary goal, but it was very much occurring as well, that I spent so long feeling that the diabetes was robbing me of a normal life. It was robbing me of opportunities, or potential future opportunities. So I kind of thought, well, do you know what? I've got this thing, I might as well use it. And learning that abuse of insulin intake can lead to weight loss, I decided to, I think I've said before, to weaponize the diabetes rather than just let it lay dormant. I was told, well, you know, I've got it, I might as well use it. So with the disordered eating, so I developed anorexia nervosa, and as I say, it was, I think, just a reaction to these issues in my life, where I felt I was losing control. So the weight loss and the fear of weight gain did feel like a control mechanism, but also felt as someone, as I said, who has very low confidence in themselves. It felt like, well, I'm failing at so many things, but I can succeed at losing weight, which sounds so irrational, but it is a irrational disorder inherently, and I think it does also link back to the diagnosis of the diabetes at such an early age, and from such an early age being so well looked after and managed. I associated adolescence with that safety net being taken away. So if I could do anything that would maintain that safety net's position, if I made myself ill, that would make people look after me. And it means I don't need to look after myself because I don't feel I'm capable of doing that. So in some ways, even though, as I say, it might not be my primary goal, I was making myself ill so that people would look after me. And I think, to further deepen that, I feel that that was a sign of love. You know, we love you, so we're going to look after you. And so it was my way, I think, of, and because even now, many years on from the event, I'm still trying to kind of untangle exactly what was going on at the time. It was incredibly complex. So I think I didn't have the words at the time to say help, because I couldn't verbalize what was going on. So I couldn't verbalize my feelings, but I could physicalize them. So I was visibly unwell. And I think that I was trying to use my body to try and, I was going to say use my body to say what my heart was feeling, but that's terrible. Well, we can edit that out later. But you know, I was trying to, it was as cliched as it sounded, it was a cry for help, and it was a cry for attention. But I feel that you hear, oh, it's a cry for help, sometimes being used as a negative thing, as something to like write off the event. But the thing is, the person is crying because they need help. So even if it comes about in a very self-destructive or disastrous way, attention must be paid, because that person might not have the means to go about seeking help in the way that it's healthy, obviously. So yeah, there we are.
So when you said that the superficial, I guess, goal was to lose weight, what did you do to lose weight?
Yeah, so I wouldn't want to go into this is all for health practitioners, isn't it? So I can kind of say something, that's fine. Yeah. I'm so ingrained now to not give out too much. So it would be excessive exercise, which really was not my style pre-teenagedom. But I think as getting slightly older, starting to have an awareness of my body and other bodies, and I was also struggling with my sexuality. So it was a thing of like, well, what's desirable in a male and is not what I currently possess. So if I exercise more, then maybe I can acquire those features. But with the diabetes, what would happen is I would go for runs for hours and hours and hours, or I'd wake up very early and then go for runs. Then naturally my blood sugars would dip. So then, as was pointed out by Marietta, so excessive exercise, your blood sugars dip, so then you eat. And I think it was that vicious cycle of, well, hang on, but I'm doing exercise to lose weight, and I'm just putting the weight back on, and it felt very confusing, which then further led to my annoyance at the diabetes, because I felt it kept getting in the way of the diabetes was getting in the way of the anorexia for such a long time. And then once the discovery came about that the abuse of insulin, or either greatly reducing or just completely omitting insulin intake, that can actually lead to weight loss in itself, that was a bit of a light bulb moment of, oh, hang on, I can be anorexic and still have the diabetes, that felt very intoxicating. So what I would do then would be continue with my extreme exercise and eat as and when I wanted, if I wanted, in certain stages. So sometimes I would very much go through starvation stages and not eat at all, unless the diabetes would occasionally rear its ugly head. But what I would do I would artificially make my blood sugar levels run at such a high level, so that when I did exercise, they dipped a little bit, but not too much. Or if I did take some insulin, they would dip, but not too much. They would dip, if anything, closer to healthy. But if I was stayed at healthy and then exercise, they would go to hypo, and then I need to eat. Or I'd be healthy and then take a little bit, and they go into hypo. So I'd make them naturally high and only dip a little bit. So it's kind of I don't know, like bowling, but with the ramps up. So you sometimes the ball would hit that side, and you course correct as you went. So it was just a general mismanagement, really, which in my head was very rational, as I say, and this makes absolute sense. But I think if you had told me of how dangerous the behaviours were, because at that time I didn't have any awareness of the dangers that this presented. It felt just very immediate of, oh great, oh I don't need to inject, oh amazing, I mean I feel crap but that's okay because I'm achieving my goals, that's fine. I had no semblance of understanding of what it was actually doing, and that might have been a willful ignorance, that might have been me trying to stay naive perhaps, but yeah, it was all quite dark and dangerous for a while.
And how did you first find out that omitting insulin makes you lose weight?
There was a lot of Googling was happening, a lot of Googling.
About how to lose weight?
Yeah, yeah, and I think this was the early 2010s, so there wasn't a heck of a lot going on in regards to diabetes, but I think that I might have seen a stray article somewhere, or I think, bless him, I think my brother was involved ever so slightly, because he mentioned that how it used to be called the wasting disease, or it was known as that because years and years ago, historically, people who had diabetes would get very thin and die, and they didn't quite know why that was. So I think, and he's, sorry if he's watched, he's a doctor, but he wasn't at the time. But he had an awareness of the biology of diabetes, whereas I was just like, just stick an injection in and off I go. I was very naive to it all. So I think him unlocking that pathway, I think. So the information wasn't readily available, but it was there if I was to really search for it. So as I say, this was a while back. So if someone in 2020 is starting to get curious or something, I feel that there'd be a lot more means for them to find this information out. So which is why it's good that things like this are happening, because then we can combat that quicker. Because I felt that I was very much left in the wilderness for such a long time. In that, maybe jumping ahead a few questions, but when I presented to my diabetic health team, it was a bit of like a what? Like, it was a very much a group effort for us all to try and figure out what the heck was going on, because it did feel very unusual at that time that someone was presenting with an eating disorder and diabetes.
That was my next question, actually. So how did you overcome this? Because now you're in a completely different headspace. So how did you arrive to be where you are now?
Yeah, I mean, I'd like to make it also clear that, I'm not tip top 10 out of 10. There's still very much some good days and bad days. But comparably to where I was, holy moly, it's very different, which is good. I think it did all really it came out in the wash in that I went to my regular diabetic checkup, because of the previous one, be it 6 months prior, they noticed that my HbA1c was disastrous, and I was trying to put on my best act, like, oh, how bizarre, that's so weird, I've no idea why I'm knowing full well why it was, it was left with the dietitian, because they're trying to introduce DAFNE, I wrote it down, dose adjustment for normal eating, and I think the NE of DAFNE, the normal eating, kind of rung out. I was like, normal eating, I don't quite know what that is actually. So I was asked to maybe just do a food journal, just because we're trying to figure out, based on your logbook, Lawrence, why the levels are so crazy or so not good. Anyway, so I totally agreed. Oh yeah, absolutely fine. Great. I'll do this. And then I think I tried one meal, one breakfast, where I had to write down exactly what I ate and exactly what I injected. And I found it impossible. I couldn't, it was I remember what it was, a strawberry yogurt, and I couldn't write down the word strawberry yogurt. I think just the fact it incapacitated me so much. I was like, there's something very wrong here. And because I'd been omitting the insulin for so long and starving myself for so long, I was miserable, and I was doing very badly at school. So you hear about folks with eating disorders being very high achieving. Well done to them, I say. I have no idea how they did it. So I wasn't doing very well. So I went for my checkup, and bless her, Catherine said, so let's have a look at your food log, and I just burst of, I don't think I'm well. And I think it was a thing as well of, part of this was me asking for help. So I think I finally found the courage, not to say that I was weak before or scared. Well, I was scared, but I'd found a way to ask. I think something is really wrong here. So that's not to say that the moment I acknowledged there was an eating disorder, and not to say that the moment a plan was put in place, I was fine. It's still taken about 10 years post that, but I still very much had to acknowledge in myself that there was an issue, because those around me were aware, but I was not in a place to receive due care and attention, because I was self-destructing. I was slowly, the goal was to kill myself, essentially. So well-meaning well-wishers, it kind of bounced off me, because I was in no state to accept help. So it took a lot of internal work to try and get to receive the help, to be in a position to receive help.
Well done for all that progress. This is the end of my questions. If anyone else wants to ask something.
The board's lighting up.
Just wanted to say thank you, Lawrence. It's very powerful, you sharing your personal story, and it's not an easy thing to do, and really, really much appreciated. Thank you.
You're very welcome. As I say, I think there's lots of issues in that I was male with an eating disorder, with diabetes, and it felt, when I looked into the media, for example, if there was a long-running soap who introduced someone with an eating disorder, invariably it was a girl with anorexia, which is obviously incredibly important, of course. I felt very confused, because I was thinking, well, I'm a boy, so boys don't get eating disorders, was my rudimentary thought. But also, I am eating because of the diabetes, so how can I be anorexic if I'm eating? So there's a lot of confusion around there. So I think it's since doing more research and reading and things like this, I'm like, oh no, because it's a especially designated EDNOS, disordered eating diagnosis. So they do exist, these mythical unicorns. I felt very much that I was alone and wrong. I felt that I was failing at having an eating disorder because I was eating. But I was having to eat because of the parachute safety net structure of the diabetes. So it's very confusing. So to have platforms like this to talk about it and to know that there are folks out there doing research, it kind of it validates that what I was going through wasn't this abnormal aberration. You know, it is a recognized thing. So hopefully it means that there will be more structures put in place for future Lawrences to know that there are folks who do know what's going on. Because it's so sorry if I'm stepping on everyone's questions, but understandably, you know, if I went to a diabetic specialist and asked them to cure my mental health, they're like, whoa, we've got 10 other things on the to-do list before we get to that, because that's not their specialty. But then also, you know, I was an inpatient at a facility in Glasgow, and for them, they had to solve, okay, this eating disorder, self-harm, depression, bits and bobs. For them, diabetes was this very other thing that they couldn't quite, you know, I think having a long-term a chronic illness maybe isn't as explored. I don't know, but in partnership with an eating disorder. So I think the more research that's done by wonderful folks like yourself, though it might seem niche or I don't know, but I think the fact that the number of diabetics are rising, then it shows that this might be something that becomes more important in the years ahead. So it's great to know that folks like you are nipping it in the bud, I suppose. I'm shutting up now.
Thank you. Thank you, Lawrence.
You're welcome. You are welcome.
I think
and Emma and Marietta, fantastic. John will pick up the questions for me. We've got a few questions, which I'll leave it to you to decide who to answer. So there's one from Jade Topping. Would taking too much insulin to cause hypos to aid in permission to eat come under the possible diagnostic criteria? Perhaps that's for Emma to think about. So taking too much insulin to cause hypos purposely so that they've got permission to eat.
Of course, you have to jump in here.
Well, it's I completely agree with that statement, because this is something, one of the cycles I haven't shown today, one of the maintenance cycles we did find in our semi-structured interviews, and which was also validated by the people who lived the experience in the workshop, saying hypertreatment used to be sweet treats. So the treatment for hypoglycemia is quick-acting carbohydrates, often in the form of jelly babies and other sweet treats. And often growing up with diabetes meant that the only treats one was allowed were hypertreatments. Hence, the discovery of, well, if I hypo, I get treats. And that cycle seems to perpetuate in adult life as something I'm only allowed to treat if I'm hypo. Where to draw the line, if this is just a pathology or whether it's something to call disordered eating or not, is something we will have to discuss in Emma's project, as in sort of this iterative process of the co-design and Delphi method, because indeed it is something that people living with type 1 diabetes who would not consider themselves having an eating disorder or would also experience. So it's sometimes difficult whether one single maintenance cycle, one's behavioral cycle constitutes an illness, or whether it's part of the spectrum of behavior you develop living with a long-term condition that links food with medicine.
Okay, thank you very much. This question from Penny. Is there any training you'd recommend to upskill eating disorder dietitians on carb counting or insulin management?
That's a really good question. I think it's not about the singularity of being able to carb count or know how to calculate the algorithm of how much insulin to give with a certain amount of carbs. It's really about understanding how insulin works in the body, but also how you inject it safely, how it can be manipulated, as in. So I think the best way of going about that is finding a befriended dietitian in the diabetology department and link up. There are, of course, structured education programs targeted at health professionals wishing to up their diabetes knowledge. So CDEP, for example, King's Health Partners are working on developing programs in the future to train people up. We, with the TIDE project, have gone out to the Tyson West eating disorder inpatient unit to help on a case-to-case basis and train up the team there. But it is really like a clash of two worlds and two paradigms here. And I think the difficulty is the sort of finding the balance between the almost mathematical algorithmic approach isn't always appropriate or healthy for a person with eating disorder, and the try not think about food and relax about this approach from the other side. It's very difficult to balance, and it's really great to know that people are out there who would like to learn more about diabetes, working in eating disorder units, in the same way as as diabetologists and diabetes dietitians would like to learn more about mental health and eating disorders, so we don't, from our side, make these mistakes as in saying, oh, what have you done there? How many carbs have you eaten there? And, oh, have you not given enough insulin? So we are on a steep learning curve here as well. So in the future, we hopefully have some training programs at the ready to recommend.
I just want to add something from the patient perspective, mostly on this area, that all people with diabetes say that we're just not just numbers, and it doesn't mean that if I carb count and I eat something specific, these are the results I will always have. It just simply doesn't work like that. And it is important not to pass on any guilt to the person living with diabetes because you've told them to do something, and because you don't see the result that you expect, hence they have done something wrong. And many people that I've spoken with actually said that I wish that there is something more than I can talk to a dietitian and get a structured diet. Of course, that is part of what some people need, because they have trouble in their first aim is to lose weight, and they cannot find a way to do it with their diabetes not being affected, their diabetes management. But of course, there is also the other aspect of people saying, I'm doing everything I can. I need something. I need a dietitian to support me, but I also need mental health support throughout this process, because it's not just about that. That's all.
Thank you. Lisa has asked, have you had any feedback from the workshops on people's feelings regarding the use of the term diabetes?
Did you get that?
So can I just try and repeat what I thought what the question was? So have we, in the experience-based co-design workshops, been given any feedback on how people feel about the term diabulimia? Is that correct?
Yeah.
Okay. Yes. Yeah. So that is a very controversial topic. And as controversial topics do, they attract very different views of whether that's a term that should be used or not used. We in the current clinical setup, we try to use the word TIDE, as in type 1 diabetes disordered eating, because it covers a slightly wider spectrum. Because diabulimia has been sort of associated with omitting insulin in order to lose weight. However, if somebody binge eats and doesn't cover their binge, is that diabulimia then or not? So there is discussion around this. So we've felt and advised by our PPI group that TIDE was the more neutral working term for now. But then over to Emma, I think this will be part of your co-design process, won't it? Have you?
Yes, we will definitely ask people what terms they prefer, but what we do know so far is that they don't really like the term diabulimia because it is quite specific and doesn't cover all experiences.
If I could interject ever so slightly as well, I during the height of the illness, I so bulimia, which I don't have as much of a working knowledge with at all, with food intake, and during the anorexia, the height of anorexia nervosa, I wanted nothing to do with food. So then to be given a term diabulimia, it seemed to reinforce the importance of food when I was trying to escape it. But I do love a good zinger. So diabulimia, it does kind of run together. You can see why it's come about. But I think I personally react well to terminology and boxing in of or labels, I suppose. I know that quite a few folks don't, but I just wonder if, for you guys, do you feel that it's helpful in terms of just as a quick thing to say during your research, or do you feel that having a purely diagnostic, an actual term, a coverall term, is useful what are the practical uses, would you say, of having such a coverall term?
So we don't use the term diabulimia in our research at all. And this is because we work closely with people with lived experience and we follow what they want. We need to find a term that they feel comfortable with, because we want the diagnosis to be helpful. And healthcare professionals can adapt. They can learn the term that is chosen and use that, because it's a different function of the diagnosis, I guess. The definition for a person with lived experience is to, I guess, feel that their disease is recognized and they can get help. For a healthcare professional, the purpose is to know what are the symptoms, the presentation, and how can I help? How can I fix this, really?
Thank you. Charlotte's raising a useful question about adolescents, because are your projects involving just adults, or they're adolescents as well?
It's a really important question, and for the time being, by the nature of the team being adult physicians and adult psychiatrists, we are setting out to test this in the adult population, but we have on our advisory board in our collaboration pediatric teams on board. For example, Simon Chapman, who's got a keen interest in this field, where we will be looking at if the concept of STEADY works in the adult population, of translating that into the adolescent age group. However, there are, as Lauren's very beautifully described, there are so many other factors going on during that time, as in transition, as in leaving the parental home, university, challenges of new relationships and all that, that we felt that at the moment we couldn't quite deal with that complexity at this point in time, trying to purely find a remedy for the combination of disordered eating and type 1 diabetes, but it would be absolutely desirable, if the pilot concept itself works, to look at expanding that into that group, because that's the age of vulnerability and the age where it often starts. Another vulnerable point in time seems to be pregnancy. So in our clinical services, you see people who manifested with their disordered eating after pregnancy. Interestingly, so disordered eating and eating disorder in type 1 diabetes can be quite atypical from what people believe eating disorders are.
And that's a whole another area where eating disorder services need to skill up managing pregnancy, because a lot of them aren't that used to it. Although pregnant women with eating disorders are becoming much more common these days. Emily is asking Lawrence, wondering how you found managing different approaches to treatment in terms of eating disorder treatment versus managing the diabetes. She says, I'm guessing, and I might be wrong, there may be some difficult bits which could be seen as conflicting. That's kind of been alluded to, but did you have a specific treatment for your eating disorder, like CBT or something like that?
Thanks, Emily, for that lovely question. So the main drive for the eating disorder was CBT, inpatient, and then also outpatient referrals within an NHS service. I guess so their primary goal was to their worries about my immediate health. So they were concerned about depressive behaviors and extremely low weight, which would have immediate health ramifications. So I do personally feel, they were trying to triage me as best they could, but unfortunately that did mean that the diabetes was left to the wayside, even though ironically it was maybe the most dangerous thing. Whereas, the diabetes, I grew to resent my diabetic clinic visits because I felt in my state that I was in, that some of my more delicate, precarious states of mental well-being were ever so slightly brushed aside, because for them, they had to get the diabetes under control. So I felt at times that I grew to resent the diabetic visits because of all that they involved. Also, constantly being told of, oh, this is getting worse, or you have to look out for this because this could happen. This could, I found diabetic visits to be incredibly distressing. I think it's the word I'm trying to look for. Which actually, I must say, my most recent visit to a diabetic clinic, I have to say, was kind of nice, because they actually took a much more holistic approach to my diabetes care, which was very refreshing. So I think, yeah, it's I don't envy the clinicians who are having to deal with me in any state that I'm in. But I think taking the holistic approach, it's hard as well, because when you go for the diabetic clinic, a lot of the time they're maybe not aware of your medical history, so they'll pop you onto a scale and read out what it is, which from the get-go I find horrific even now. So I think, I don't know, I don't know, I think it's, you go to a diabetic clinic to sort your diabetes. I went to therapy to sort everything else, which bundles up. So if I was going for, I don't know, to the dentist, I wouldn't want them to know about my diabetes, really. I don't know, that was a terrible comment. Ignore that.
Okay, thank you. And there's one final comment, which kind of really illustrates the point about living as professionals in very separate worlds. Somebody's saying structured diabetes education like Daphne, etc., is not offered to mental health dietitians. So we clearly need the work that your team, Marietta and Emma, that you're doing is desperately needed. And I'm really looking forward to the results over the next few years. I'm going to hand back to John, and he's going to do the poll questions that we set up a day or so ago.
Thank you. Yeah, so we've just got 4 questions that came from the poll. So the one with 18 votes was how would you detect when someone is emitting insulin? Marietta, as a clinician.
So I think it's probably a dual response from Lauren and myself. So as in what would your clinician have asked you to find out? I mean, from a diabetes clinician perspective, if somebody takes less insulin than would be healthy for them, the HbA1c, that is the glycated hemoglobin A1c, is a really good mark of the average glycemia of the past 3 months. You would see that one going up. And sometimes it's just a okay to ask. If some of your alarm bells ring as a clinician, you're worried, you could just ask, do you ever take less or more insulin than you feel you should? And why is that? And you may get an answer or not. So Lawrence.
Yeah, because that is the danger of if you are presenting at a time of ill health, and that's when the alarm bells are ringing for the clinician. The chances are, if I'm taking my own case example as a point, I was incredibly duplicitous at the time. You could not have got me to admit to my behaviours, which is incredibly tricky. So again, that it's not an enviable position at all. I was at that time in my adolescence, so I'm not sure the parental rights of intervention. I'm not too sure. Yeah, yeah. I mean, it's when the numbers are in front of you, the numbers aren't lying. I tried so often to blame it on faulty technology. I mean, I was kind of scrabbling for any excuse there at that point. But I think so. I think that's when, if the HbA1c is high, there's only very few number of reasons, I believe, why that would be the case. So I think it is up to the wherewithal of the clinician on when to intervene in that case.
Yeah, and sometimes both the service user and the clinician see that elephant in the room, and then it's about finding the right moment to talk about it. And as with any long-term condition, it's very much about a trustful relationship to your healthcare team, feeling comfortable talking about your life outside diabetes, because that's actually the more relevant one. So the usual "how are you" question as an iterated for further, as in what's going on in life at the moment, before you then actually look at glucometer downloads and other things, you can more easily contextualize it. And if you start with that question, you often get I'm having a horrible phase in life at the moment, this happened and that happened and a breakup at that. Well, then you make sure you meet your service user fairly soon again and check in on them, but you're probably not going to challenge a phase when we all would sort of only do the most necessary to bumble along. And just if you happen to have diabetes, well, that sort of gets visible in the numbers on your glucometer or your HbA1c. But if you didn't have diabetes, everybody has phases where they don't look after themselves well. So to have a bit of understanding and tolerance that's part of life, whilst keeping a check on to make sure people are safe, it's a different balance to strike as a clinician, so you're not too patronizing in your care delivery.
Are repeated admissions with diabetic ketoacidosis common as a kind of way of finding out that this problem's happening?
Yes. So an admission in diabetic ketoacidosis, if it's not at diagnosis or if it's not in context of another severe illness, so for example, at the moment we live in the time of the pandemic, so we have seen people who normally are not DKA prone admitted in DKA because of COVID. It should ring alarm bells and should the clinician should ask about what happened in the run up to the DKA admission.
Okay, so next is, what are the indicators of high risk? So people put into that one.
Yeah, so again, from a physical health perspective, that will be high HbA1c or low body mass index, repeated admission, diabetic ketoacidosis, and severe hypoglycemia. So these are sort of the severity indicators, but then we're probably looking at a continuum when it comes to HbA1c, so we are not always discussing where to set that cutoff. But these are the severity criteria we're currently working with in our NHS England funded pilot in the London site.
Okay. And the next one is, are there any effective ways to increase awareness of the risks being taken and motivation to change?
I think it's more about awareness in the health professionals, as in how, but this is a thing, it exists. We have to take it seriously, we have to work together on this. There's a bit of a phenomenon of avoidance with conditions you're really worried about, where you feel out of comfort zone. As a diabetologist, you're not trained to deliver mental health care. As a mental health specialist, you're probably not trained to deliver physical health care as much. So I think it's about, this is where I would raise awareness that we need to work together on that. I think people living with the condition is often not about making them aware of the risk. I think they know. But would you wish to comment on that, Lawrence?
Yeah, I mean, I wonder if it was the diagnosis when in the 90s, so things were ever so slightly rudimentary back then. B, I was an absolute child, so I wasn't privy to the conversations that were undertaken between the clinician and my parents, even though they were aware, as I say, due to other family members. But it's a case of you not wanting to front load too much information. You know, if you've just been diagnosed or your child's just been diagnosed, you don't want to hear, oh, by the way, this could happen 20 years down the line. But I think my partner's diabetic, and he said that when he was diagnosed in his teens, his parents have said that they don't feel that they were kind of given, if they were given adequate information, maybe they were too much of an emotional state to really take it on board. But I think early intervention or early information is vital, because the danger of diabetes is, I felt for a very long time that I was having to react to the immediacy of the condition. Oh, my blood sugar levels are dropping now, so I need to act now to get me out of a hypo, not really realizing that the long-term effects are the things that kind of really scupper you later down the line. But you try and tell a 14-year-old that, oh, you need to look after your levels now, because when you're 40, you might start to develop eyesight issues. You know, that feels so far away, but there is the danger of the behaviors that you undertake right now can have long-lasting effects. So I think in regards to adolescence, it's particularly tricky to really imprint that on someone who they're maybe a rebellious part of their life, or they can't see that far down the line. So I think you don't want to scare the person, you don't want to depress them further, but they do. It's a very delicate dance of just imprinting just how important your health is at that time, but not wanting people to feel too overwhelmed. It's kind of the case of, you know, your diabetes will always be a part of you. There's no ignoring it. There's no running away from it, but it doesn't have to be all of you. It's part of you. And I think it's trying to just develop the relationship between the patient and this very nebulous kind of other part of them. It's again, I'm not envious of the folks who are in charge with patient care. But yeah, it's very tricky.
Then the final point was liaising with diabetes teams. I guess it's like, how might an eating disorder service best liaise with the diabetes service?
I think every trust will have their local diabetes services to liaise with. I think it's good to have somebody local to talk with, because if you are looking after the service user together, it's good if both parties know them. And if you join up the care, you already avoid that problem with the conflicting messages you deliver. And so if I've got somebody I look after in the clinics, I quite like to make contact to the psychotherapist with their consent, obviously, and vice versa. So we're not going so we're all on the same page, and including the service user, what the next plans are. And that's not necessarily around eating disorders, it's also around depression and OCD and other mental illnesses that are not too uncommon in type 1 diabetes. How to do that practically probably depends on the setup where you work. Befriend a diabetologist in your trust.
Okay, fair enough.
Can I come in there? Locally, we've I realise I'm disappearing into the dark here. We find the diabetes nurses very, very helpful. I was trying to encourage my staff to do joint appointments with the diabetes team and with the dietitian from the diabetes team, if at all possible, as well. And they're very responsive to email as well. So we're always banging questions backwards and forwards, and they're giving, sending them glucose readings, and they send us back, tell us what to do. So I definitely recommend befriending diabetes nurses as well.
I think that kind of brings us to the end of the questions, and it's just been so brilliant to have you come and share your experience, lived experience, clinical and academic experience. So thank you so much. So this will be available to view on the BREDS workplace afterwards, and it's kind of starts the conversation more. So you can, if you think of any questions or anything, you can still add them to the discussion there. But yeah, it's such an important problem, a difficulty that is seen in eating disorder services and diabetes services. So thank you everyone for taking part, and I'll end this live stream on Workplace. Thank you very much.
Thank you.
Thank you.
Thank you, everyone.
Thank you.